Well, thank you, Sarah, for that introduction, and good morning, everyone. And let me add my welcome to this year's Addiction Medicine Essentials 2020, and welcome to what we are hopeful and sure will be a really powerful conference and useful for all of us. As you know from the introduction from Sarah, I'm in a somewhat peculiar position of being inpatient at the Duke COVID treatment, or the treatment units for COVID-19, and so I'm giving this as a pre-recorded, a live, albeit pre-recorded presentation. And I was really eager to do that. I didn't want the gap in the schedule, obviously, but also I had some thoughts and conceptual and practical information that I really wanted to make sure I had a chance to share with y'all. So I'm looking forward to doing that. Many of you, some of you may have been at last year's Addiction Essentials Conference. When I led off with a presentation on basic concepts in addiction medicine. What are some of the core concepts that have come to sort of dominate the field and define what we see as substance use disorders and their identification and treatment and recovery. And so it occurred to me that, given the past 9 months, it would really be useful to revisit that and think of that in terms of, what's the same and what's different in the setting of applying addiction medicine basic concepts in the setting of a terrible, devastating viral pandemic. And so I'm glad that we're going to have a chance to do that, because a lot of the concepts that we talk about were somewhat controversial when they came out. They were debated and whatnot. They're pretty well accepted now, but they really, I think, come home to roost in some interesting ways as we apply them now. And as many of you know, I really try whenever I'm doing these presentations to let it get conceptual and let it get philosophical, but make sure it ends up being practical, that we have some suggestions about what this means in terms of day-to-day practice, regardless of where that is. So core concepts in addiction, what's the same, what's different? Addiction Essentials Conference 2020. I'm going to provide a brief overview of the impact and challenges of dealing with dual pandemics, brief update on the epidemiology of SUD since the COVID, although to be frank, I'm not going to get real detailed about that because we're going to have a really great presentation on that tomorrow. But I want to give enough background to kind of give background to what I'm going to be talking about. Review the core concepts in terms of what's the same and different, outline and explore some of the clinical challenges for addiction medicine during this time, and give particular attention to adapting to the challenges of providing access and good clinical care in the setting of social distancing, maintaining connection in the setting of telemedicine and masks. Now, as I started preparing for this some time ago, there've really been some interesting perspectives put out there. Many of you know David Filin is really an excellent academician and clinician, and it's been really, really important in the whole dissemination of medication-assisted treatment. And so he very early on with a colleague published in the Annals of Internal Medicine, When Epidemics Collide, and talked about some of the potential consequences of COVID-19 with infection risk in persons with OUD, increase of opioid overdose rates, the potential for reversal of gains and expanding access to medication, of halting critical research, of preventing legal reparations against opioid manufacturers. And I thought it was a really striking list, and unfortunately, pretty clear that most of those things have been coming true. Nora Volkow took a somewhat different approach to this collision of epidemics, and she focused a bit more on the clinical impact of the potential for more severe COVID consequences among opioid use disorder patients, compromised lung function, other medical comorbidities, marginalized and underserved populations with housing, healthcare access, et cetera, things that we're going to hear about in great detail from some of our follow-up speakers. Increased social isolation, decreased access to support, and of course, just increased substance use in general in the setting of COVID-19. And again, predictions from April that have been more than more than prescient, although probably pretty obvious to everyone concerned. So it's a bad situation for individuals with opioid disorders, for substance use disorders. And so how do the core concepts of addiction medicine apply? What's the same, what's different? Well, if you recall, those core concepts were the acceptance of a chronic disease model of substance use disorders, and that disease model exists along a continuum from non-problematic to mild to moderate to severe problems. It emphasized the critical importance of attending to mental health comorbid conditions. We know there's just a range of comorbid medical and psychiatric conditions associated with substance disorders, but there really is an important emphasis on let's not ignore the mental health comorbidities. Many of you have been around long enough to know that there were times where it was all about the addiction, and if the person was depressed or anxious, you just took care of the addiction. And we've become much clearer on no, you really have to address both mental health comorbidities as well as addicted morbidities. The utility of a collaborative motivational intervention mode of interaction and intervention has become really a dominant alternative to the my way or the highway, confront and deny sort of treatment modality. And the utility of evidence-based behavioral therapies and making available medications to assist therapy are all considered some of the core concepts that we try to apply. Well, looking back at those, in preparation for this, one of the things that immediately was interesting to look at was the public health model of disease as applied to alcohol use disorders or addictive disorders. And just to frame how important this was when the field shifted away from an all or none, have it, don't have it, black and white sort of concept of substance use disorders, to seeing them as this dynamic interplay, who ends up having problems and how those problems play out and how problematic they are, is this dynamic interplay between the host, the agent, and the environment, and with a real increased awareness of how important the host issues of emotional stability and psychiatric comorbidities or emotional comorbidities are, and how critical the environment is in turn, access to care and access to treatment and resources and support and all of those things are in terms of who gets and who recovers from addiction. And again, I think some of our other speakers will come back to this in some interesting ways as time goes on. So a public health model that really broadened how we think about disease as it applies to substance use disorders, but with this clear understanding that it also exists along a continuum. Again, it used to be this all or none sort of perspective. And now we really recognize that substance use disorders, share a lot of characteristics, a lot of symptomatology, but that how that manifests ranges across a continuum from sometimes mild to moderate to severe. And we really have to be thoughtful about that and not see everyone as using a drug as having an addiction to that drug. There are certainly salient characteristics that mark out people who have genuine addictive, severe kind of disorders. But for most people, as we know, there are these continuums. So this graphic representing alcohol use disorders as they present in primary care patients, with this distribution of most people having either no problems or moderate problems, and a relatively small percentage becoming actually dependent or addicted, and a significant portion between that do have problems, but the problems are more amenable to change than they would be if the person was in the addictive category. And the same sort of diagram you could draw for opioid misuse and abuse. We could do similar diagrams for marijuana, cocaine, even things like heroin, where a lot of people are surprised to find that there are large numbers of people that chip away at heroin for years without ever progressing to a real addictive sort of pattern with it. Now that's gotten harder to do with the onset of fentanyl, et cetera. But still, nonetheless, this sort of pattern plays out in any drug you want to talk about. So keeping that in mind, that these are addictive disease, chronic disease sort of disorders, and that they typically exist along a continuum. What's going on right now? Okay, and I'm again not going to do a lot of detail here other than to just, point out that if any of us thought the pandemic, the viral pandemic was going to sort of blunt the opioid epidemic, that got put to bed really, really quickly. This is a large lab report study looking at lab screens before and after the onset of COVID disease, and you can see things didn't go away. Likewise, reports from across the country, at least 30 states at the time of this June 2020 report by AMA, over 20 states were reporting increases in opioid-involved overdose deaths, particularly related to illicit fentanyl. And then just rates of substance use, not overdose, not necessarily addiction, but just use. Addiction Policy Forum did a NIDA NIH supported survey of patients in recovery or their family, or their family members, and found that 20% of the families reported that they or their family members' substance use had increased because of COVID. And the CDC put out a publication in August of a nationally representative population. In other words, not substance users identified, but general population survey study that showed a 13% increase of people reporting starting or increasing substance use to cope with stress or emotions from COVID-19. So there's, without getting into more detail, it's no surprise to all of us that folks with substance using disorders are at risk of or are already using more of substances, and that the general population is turning to an increasing degree to substances as a means of coping with the various and sundry stressors of this situation. So what does that mean in terms of our core concept? Well, the main thing it means is we know things are increased. We got to get curious. We got to be talking to people about, are you using, or have you increased your use of other substances? And we have to get curious and stay with it enough to figure out, is that use sort of low risk, not problematic appearing, high risk, is it actual substance use disorder, mild, moderate, or severe? And that means we really have to take time to ask those questions, even if it's someone who's been stable on medication-assisted treatment for years, even if they've been sober for years, even if it was never their drug of choice, even if they never had a problem with benzos or booze or weed. And don't forget to ask others in the family. Is anyone in the family that you're worried about getting into more drinking or drug use? And I think, we'll come back to this when we talk about maximizing, the benefits of telemedicine and whatnot. I think telemedicine really gives us a good opportunity to be able to ask these kind of questions and get some of this information on the table. And it doesn't mean, again, that we're identifying people as being addicted or whatnot, but we're able to start having that conversation. What do you think the goods, or what do you think the risks are of you using alcohol as a way of dealing with the stress you're under? What do you think it means that your pot smoke use your weed use is really going up? And it's not an evening thing anymore, it's a more common thing. It's just starting that dialogue, getting it on the table, helping people look at alternate means of coping other than drug related. Okay, well, what about this core concept of the importance of dealing with mental health and emotional issues? There's a really good CDC, MMR, WR that came out in August, not that long ago, looking at mental health, substance use, and suicidal ideation during the COVID-19 pandemic, US, June of 2020. It's a national representative population survey of adults 18 or older with subgroups identified. And they basically looked at April to June 2020. They had some data that gave them comparisons to the same period in 2019. 41% reported at least one adverse mental health condition related to the pandemic. And if you look at the subgroups, it really gets dramatic. 75% of young adults, 66% of those without a high school diploma, 52% of Hispanics, 66% of unpaid caregivers, 54% of essential workers, with significant percentages complaining of anxiety disorders or depressive disorders, generally in multiples of what they were reporting in 2019. And certainly a high percentage of people reporting trauma or stress related disorder applied to the COVID illness situation. When it got into reporting on suicidal ideation, it put me back on my heels. So when they looked specifically at reporting having seriously considered suicide in the past 30 days, the overall number was 10%. 25% of young adults, 18% of Hispanic, 15% of non-Hispanic, Black, 21% of essential workers, 30% of were self-reported unpaid caregiver for adults reported having seriously considered suicide in the past 30 days. Now, I don't know about you, but I've been talking to a lot of people about being stressed, about being depressed, about being anxious. It was not on my radar on just how seriously that was impacting the people to the point of active suicidal ideation. And it's something I'll be more assiduous about paying attention to. So, you know, the obvious practical application from that in terms of clinical application, again, we got to be asking. We got to find time to ask. We got to make sure someone is asking. If it's not us, it's someone on our behavioral staff, if we have such a person. If you're comfortable doing that with basic interview, if you want screening instruments that can be part of your routine follow-up, those are available as well. But again, we got to be paying attention. And forewarning, this is not the last time the phrase "we have to find time" will come up. You know, there are plenty of treatment modalities for these issues, plenty of psychotherapy, very well validated. Access is an issue, obviously. What do you know about who's providing telecounseling? What's available in terms of online meetings or support? What's available through churches or spiritual support? But to recognize that we're going to have an increased role as the prescriber or a medical clinician being the support or counselor role, that we're going to be the port in the storm, the person that they can talk to or talking to on a regular basis. And I think that's something else we need to be getting comfortable with. Okay, the other core concept was access to medication treatments available for addiction. I think one of the things we've all been guardedly optimistic and pleased with is how, with the flexibility that was shown with telemedicine and with some of the federal guideline relaxation and whatnot, that we have been fairly successful in maintaining access to medications for those who are already on them. I think it's a challenge, obviously, for getting people into treatment and doing inductions and new patients. But I think, you know, the medication treatments with their relatively strong risk safety profile and relative ease of use have really made it quite accomplishable for us to work towards making sure this does not interfere unnecessarily with providing access. Now, we were in the midst of some really severe challenges with job loss of insurance, loss of financial support, and of course the ongoing disparities in access to care that we'll hear about have shown up much more dramatically than I think people were acknowledging. So one of the things I'd like to spend some time talking about is this treatment of opioid use disorder during COVID-19. And what are our experiences been like? What's it been like trying to do that with social distancing and telemedicine? And I'll come back to that in a couple of ways. But for right now, just in terms of the idea that one of our core concepts is to maintain a collaborative, interactive form of treatment and counseling and behavior change with individuals. And how do we do that in this setting? There was an interesting article that came out not too long ago, treatment of OUD during COVID-19, experiences of clinicians transitioning to telemedicine. It was published in Journal of Substance Abuse Treatment fairly recently. Semi-structured interviews early on, April 2020, with waivered butte prescribers, not a lot of prescribers, 18 in 10 states, who were putting at least 50% of their time into outpatient medical treatment. And to look, the goal being to describe how telemed was being used, barriers encountered, and qualities of care. Now, it's a relatively small group, but I think they came up with some, pretty interesting responses and things that we can kind of compare ourselves to and use as a point of discussion going forward as we try and figure out just how are we going to pull this off. So as you can see, 72% of the participants really saw no in-person visits. That was a dominant modality during that period of time. For the large majority, used some combination of phone or video, and a small percentage of participants did see some patients. A few saw a significant number of patients in person. Many reported using clinical judgment to quote unquote risk stratify, giving variations in the frequency of drug screens from decreased to none at all, fewer visits, longer prescriptions, choosing whether or not to see new patients. And really a lot of the participants in that report said that they were not doing inductions, they were not doing new patients except in fairly narrow situations, people coming directly out of inpatient, for example. There was variation in the use of ancillary staff. I actually had a hard time sorting out what they meant by that. It sounded like they weren't seeing people face-to-face, but they were using ancillary or nursing staff to actually do face-to-face evaluations. There was no reference, oddly enough, to use of injectables, Vivitrol or Sublocade, and the need for face-to-face interaction in that regard. Perceived impact on quality of care. Generally, the consensus was no significant negative effects on quality of care noted. General sense that it had gone well. There were some perceived benefits noted: increased convenience, decreased sense of risk for the patients, reduced no-show rate, being able to expand scheduled visits to outside usual business hours, providing access to some sense of the person's home environment of the patient. There were concerns. Nobody was completely satisfied with it. I think we hear that amongst ourselves. Concerns about subtle decrease in connectivity, some concerns about not being as reliable in terms of picking up on lying or risk of diversion and whatnot. There were certainly difficulties with flow visits, tech glitches, freezing, dropping, lack of access for some. And then a pretty overt reference by a number of the participants, the challenge of finding adequate referral for telecounseling, quote unquote, many have just closed up. So a series of reactions that I think some of us can identify with. I would share that, my personal experience and the experience of Dr. Arami, my partner, and I, is that we jumped in pretty quickly. We moved to phone and televisits almost exclusively, with very few exceptions for injections, but we did have probably a double handful of patients that were getting Sublocade or Vivitrol, and it's really hard to do those virtually, and have more or less stayed in that mode. So it would be interesting during the discussions when we break into small groups and whatnot to explore how many people are still in that mode, how many people have expanded face-to-face, how many people are doing drug screens, how frequently, et cetera. We essentially dropped drug lab testing for quite a length of time, and then implemented collections with strict social distancing, et cetera, when we thought it was needed, but we still are doing that on a decreased level than before the COVID. We feel, as the participants did in the survey, that this was done without evidence of a significant negative impact on clinical outcomes. Now, granted, I have a fairly stable patient set, Dr. Rami less so, Yeah, we continued to admit new patients, continued to do inductions. I did just recently a closely managed home detox for severe alcohol use disorder, all video with ancillary support. And it went perfectly well. The only complication was I got sick before he got completely well. And so it was a little bit of challenge on the last couple of visits. But otherwise, we really feel like it was possible to implement this pretty quickly, and the overall thought is it has not seriously negatively impacted the quality of clinical care or outcomes. So let's talk about quality of care. Let's talk for a few minutes about expectations of care, because I think we're in a very interesting experiment right now for the last number of months. And I think it's something that we need to be talking out loud about and thinking through. You know, as I've said, in looking at these basics of addiction medicine, the basics are the same. They're very, those core concepts, I think, are very actively in play and need careful application. The specifics we're figuring out as we go along. I mean, if you think about it, many of what we consider the standards of care, frequency of visits, frequency of drug screens, dosing levels, standards of monitoring, approaches to intervening with aberrant behaviors, are largely based on consensus opinion with very limited solid research support. That came out real clear when the CDC was trying to come up with their guidelines on opioid prescribing, and they were reviewing all the literature, a lot of which came from the addiction field and whatnot. And it became unclear to a lot of us that a lot of this is stuff that we're doing because it makes sense and it seems to work. But the idea of how often you see someone, how often you do a drug screen, that's pretty open. So we're in the midst of seeing how many of these are challenged by the current clinical scenario. We're all actively in the midst of resetting the standard of care expectations. So, clinical perspective, summary number one, that doesn't mean the guardrails are down, right? Or I think the one I like is bumper guards. You're bowling and you got the bumper guards because you hope the ball's kind of staying in the lane, but you're glad when it's got that bumper guard to bounce off, maybe bounce off the other side, and you go, oh, maybe I need to change something here. So, the guardrails aren't down. It means keeping access and safety foremost. We have to use the access and tools we have to rely on our own use of conscientious clinical judgment. That's what it's always been. Right now, we're kind of doing it a little more by the seat of the pants, or at least without that sort of secure feeling of at least we're doing it the way everybody else is doing it. Now, again, I think we'll have plenty of workshop opportunities over the next 2 days where we're doing clinical discussions and discussing inflammation, responding to different behaviors and whatnot, to be sharing, how are you doing with this? How often are you doing drug screens? How often are you seeing people? What are you doing when you're starting to worry that somebody's having trouble and yet you can't call them in and sit down and talk with them? Okay, we need to keep working together on this. And one way for me to that I've been thinking about that is we just need to figure out how we get more points on the graph. If you think about it, traditionally our monitoring points on the graph were face-to-face self-report, drug screening, and level of participation. Those are the things we kind of, hung our hat on of, okay, these all look like the person's in a safe place. We've always felt we needed a little more. It's not like we always felt great about, relying on drug screens and whatnot. So, what do we need to do to get creative on how to access more points of information on people if we can't rely as much on safely getting people in for recurrent drug screening or face-to-face visits? Do we want to start doing unscheduled video calls? We've got our regular scheduled calls, but how about a late afternoon? We know we're a little worried the person's using something at night after work, a little late afternoon call saying, I know this isn't scheduled, but I know you've been stressed. How you doing? What's going on? And you got the person on video and you get a wealth of information about how the person is handling their stress in a time that might be a risk for them. It also means that we do some longer, more interactive calls where we ask significant others to get on the phone and we get that extra ancillary information. still selective use of lab, but it's interesting that if I think about, diverting some of the time and energy I put into collecting labs into doing some of these other supportive interactions, there might be a win-win in that. So once again, this may need some real thoughtful attention to adapting current scheduling, finding more time, finding ways to do this in time-effective ways, and to do it with the patient's consent and understanding. Okay, so I'm getting into this last aspect of basic concepts in addiction, the use of collaborative motivational interventions, client-centered counseling style to elicit behavior change, intervention tailored to the patient's stage of change to resolve ambivalence, expressing empathy, develop discrepancy, avoid argumentation, roll with resistance, support self-efficacy, all concepts that those who are going to do the motivational interviewing, counseling workshop will get a chance to really think about and talk about. If it should feel more like dancing than wrestling, to use my favorite quote by Bill Miller, well, how do you dance via video? How do you dance with a mask? How do we maintain this core concept in a time of social distancing and clinical social distancing? Okay, so how do we adapt to social distancing and move to a collaborative telemedicine as maybe one of our dominant modes of interaction, folks? Well, some basics, right? We know and this would have been a much more detailed slide had I not gotten sick, but to be frank, you probably don't want to be getting information about regulations and modalities and platforms and such from me anyway, but just to, recognize that we're in a nice situation right now where the regulations have really been given a great deal of leeway to allow for reasonable judgment on using a platform or modality that allows you to provide the service and get the job done, with some caveats about Skype and FaceTime that they're a little too public and whatnot. So spend a little time making sure that you've talked to somebody about your platforms, about their privacy, their protection, the quality, some of the other apps and whatnot they have with them that might make this process easier in terms of implementation. And to keep in mind that some people won't have access to video or be capable of having internet access, and that you're going to be doing some phone calls too. And then to, before leaving this particular basics slide, to keep in mind, if you're going to be seeing people in any setting, if you're going to be doing injections, if you're going to be doing limited urine drug screening, if you're going to be bringing people in for evaluations because you feel like that needs to be done before you can do an induction, really think through keeping those encounters safe. Okay, telemed, prepping for the dance. Okay, well, the first thing I think in prepping for the dance is attitude. We got to think it works. We got to believe that it works. And I think if you haven't had a chance to read up on, the articles validating the utility of telemedicine, telepsychiatry, they're copious at this point. There's plenty of evidence. There's plenty of evidence that it works well, that it's effective, that it provides good care, that people like it. There are limits to it in different ways. There are challenges, but it's doable. And there are actually some significant, genuine advantages, I think, that we've already talked about. I think it's important that we're preparing the patient, we're preparing ourselves, setting the stage, keeping it focused. And I'll spend a little more time on those ideas. Preparing the patient, again, there are courses and certifications in telemedicine, right? So you could spend hours and hours getting yourself further trained up in this. Some of you maybe already have. I'm going to hit the high points. I'm going to hit what for me have been basic, what I've heard from particularly telepsychiatrists and psychotherapists that have been making much more use of telecounseling than I have for a while, and just provide some heads up for folks about some core things to be thinking about to make this as successful as you can. Preparing the patient, you got to have a discussion about privacy, informed consent. You may be someone that, most people advise that be a written informed consent. I think it's also reasonable that you, at a minimum, are having a discussion with the person about, there are privacy issues. I want to make sure you're comfortable with that. What should you expect in terms of scheduling, notifications, backup, reassurance, reassurance, reassurance. You're going to get your meds. We're still able to do the e-prescribing. We're still able to get your meds in, whatever the system is that you're using. You know, if we have drop calls, you can get back to me. If, you know, there will be follow-up, there will be availability. I think this is a time for reassurance for all our patients about those things. Privacy, private space. Can you be, you know, to the patient? Do you have a space where you're not overheard? If you are overheard, does it matter? Can you keep others out? Can you minimize discretions? I don't know about you, but I'm sure if you're like me that I'm having encounters where the video comes up and the person's driving. The video comes up and they're they're trying to find a storage closet at work where they can talk privately. Just help them anticipate that, and also refocus them. No, I really do think you need to pull over and find a safe place for us to talk. My favorite recently was I was having a telephone, it wasn't video, follow up with a patient, and we're about halfway through the med check, and he starts cussing, and I'm like, "What's going on?" And he said, "Oh, I can't get the damn pin out of the oil pan." I go, "What?" And he says, "Well, I'm changing the oil on my dump truck." And so he was under. I said, "Next time, I don't want you under the truck when we're having our phone call." But people are just multitasking like the rest of the world. And I think trying to get the idea that, look, this is focus time. This is time for you. Let's make sure you've got private, safe time where we can really, really talk. Preferred setup, laptop, desktop, phone if necessary. It's nice to have something where they can really prop it and secure it and make it stable at eye level, good front lighting, advocating for people to use headphones or earbuds so that they can, you can drown out secondary noise, and also to help with some privacy. Prepping yourself. Okay, you gotta prepare the tech. You gotta decide your platform options. You gotta set it up, and you gotta practice. You don't want doing that the first time being when you're trying to connect with a patient. So do it with other staff. Do it with family members. Practice with it. Set the stage. Many of you know at this point you want eye level, you want front lighting, you want some sort of audio headphones. You want to be thoughtful about what kind of dress you use. I thought that was my dilemma today. I didn't want to do the hospital Johnny. On the other hand, all I had was the shirt that I'd come into the ER. So, I'm going with kind of a sort of a hale but not so hardy lumberjack today, rather than my usual professional button down. So, think about things like dress, think about things like background distractions, minimizing distractions, minimizing noise while you're going to have. And then the hallmark, the sine qua non, I think, the really important thing to keep in mind is make it focused, make it clear it is their time and your focus. Maximize eye contact, always come back to eye contact. We know we're doing scripts, we're doing scheduling, we're doing this, we're doing that, but always come back to the eye contact. I think this was brought home. And make sure you're giving it priority. That is a priority designated time where you're going to focus on that one patient. Some months ago, I had a call scheduled, and I was getting behind. I'd had some longer ones. I was behind. I saw the next person on the schedule, realized, this is going to be pretty straightforward. Rang on, did pretty much how are you doing? How are your meds? What refills do you need, etc. It was a real brief call, and then several days later, I get a nice letter saying, Dr. Finch, that I was really offended by that call. It seemed like you took about 5 or 10 minutes. We didn't have our usual, talk about different things going on, etc. And oh, by the way, you charged me the usual fee, and I'm kind of ticked off by about that. And I went, oh my God, he's absolutely true. Every single thing he said was absolutely true. I called him back. I said, look, I apologize. I'm getting used to this telemedicine stuff. I let myself get pulled along. You're absolutely right. I'll cut the fee down to a basic brief office visit, because that's what it was. And how are you doing? Do you want to schedule an earlier follow-up? And said, no, I'm okay. That clears the air. I'm okay. And it really was a wake-up call to me that I got to be careful that I'm not multitasking or taking advantage of the person's time in that way. Something that's harder to do when they're sitting in the room with you. Okay, I think one of the things we need to recognize is that for many patients, we are currently the only safe portal to access of support and information at a very scary emotional time. And that this is a real opportunity for collaborative relationship building. I'll get to one of the personal references from having picked up COVID myself is when I got that diagnosis, I got real information hungry, as I think many of us do. I got scared, and I got real, I knew it was most likely going to be mild. I knew most likely I was going to recover, but I really wanted information. And I'm a physician with a fair amount of decent knowledge base and pretty good access to information and whatnot. But there were things that I just couldn't get answers to, and it was driving me crazy. And especially when I started getting sick and going downhill, and there were things that I just could not get answers to. And it really, has pointed out to me just, both what an important role we have in this, and being this only portal for a lot of people, and that how important it is going to be for us to be available to answer questions we wouldn't normally be answering, but questions that we need to be available to answer. And also that the potential of that is a real relationship builder. It reminds me of early on when I was first doing buprenorphine, and I used to do in-office inductions, and I would make a whole ritual of handing the person the medication, having them take it in front of me, sit with them for a while, and see that I see them feel better, see them feel less anxious, see them start to feel better physically, and how powerful that was as a relationship builder and early in the therapeutic relationship. And so I think we really have an opportunity that if we can find ways to use our time, our staff and our colleagues' time and the technology, we can potentially reset what may have been fractious or gotcha relationships and turn them more into a let's help get through this kind of therapeutic relationship. And I really think that's an opportunity we have the potential to take advantage of. Okay, so that kind of transitions me towards the close of the presentation, where I really do want to finish with some personal perspectives from my time with COVID. I feel like we did our best to provide access but stay safe over the last 9 months. I did become infected. It took 8 months. I chose to interpret that to mean we acted pretty judiciously, that we did the best to minimize exposure. Nonetheless, I was exposed somewhere. I don't think it was at work, but I don't know. What I do know, in looking back at contacts, appointments, mass behaviors, staff behaviors, my behavior, I had no contacts with patients or staff that represented significant contact. I feel comfortable that this one stopped with me. And personal perspective, I can't tell you, but I feel sure you understand how important that is to me emotionally and professionally, and how important I believe it would be to you as well. So this is no time for COVID fatigue. This is no time for getting lax. We really want to be in a position that if something does happen in terms of transmission, we feel like we really have done the best we can to minimize that risk. We're human, our patients are human. We get tired, we get busy, we get stressed. Unexpected things happen. Patients show up wearing their mask as a chin diaper. Patient knows it's a phone visit but shows up anxious or freaking out. You've been conscientious all day with your mask, but you have it you find it hanging off your ear as you start to realize you're starting to pass another staff member in the hall. Set things up to minimize the unexpected, to maximize distance, clear messages, limited access and time in the interior if you are having people come in. Work from home, talk it over with your colleagues and staff, make sure everybody's comfortable and consistent with that. And think about, this is, as I get ready to go, hopefully back into dealing with folks over the coming week or so, start thinking about the risk benefit for every potential patient contact. Is it needed? Is it needed? You know, we're in this for the long haul. All of our practices have their own challenges. Mine are mild compared to those in community clinics or rural or other development areas. I know I'm talking to conscientious science-based clinicians. I'm certain you're doing your best to balance access to care with safety. And by safety, that means you and your staff too. The long haul. The stats for substance use disorders and mental health are getting worse, not better. And believe me, no one has more gratitude at this moment for the resources we have available at Duke and UNC and the other tertiary centers around the state. But we have got to maintain and improve access for primary care and substance use disorders and mental health services in our communities. Substance use mental health populations are underserved populations that are going to continue to be hotspots, and access to our community health centers, our OTPs or offices and clinics has to be maintained. We need to get through this. We need to get through the fall. We'll certainly still be talking our way through this in the spring conference. And that means you and your staff have to stay healthy. I give you these perspectives not to scare anyone off. I hope to intend to be back out there working with folks in the near future. But for that potential to be back out there, I want to take a moment to express a profound sense of gratitude for my partner who's been doing yeoman's duty, providing excellent professional care to my patients, to my colleagues, Dr. Greenberg at Duke and Dr. Erica Pettigrew, a UNC Family Medicine doc, that both helped me with their knowledge of what resources were available in the community for outpatient treatment for those with active COVID infections. And that's some information that I want to make sure we get posted, you know, during the conference or after the conference, just to make sure folks are aware of what is available for your patients that do test positive in terms of getting outpatient care, even if they can't come to your office or come to their primary care office. And finally, I want to express gratitude to the team of knowledgeable and caring clinicians that have given me such good and reassuring care during my recent time here on the Duke COVID unit. Nursing staff, of course, but also Dr. Ben Kaplan and the ID wizard extraordinaire, Dr. Cameron Wolf. They do restoreth my soul in the bosom of humanistic science. And I want to thank you all. So welcome back to the welcome again to the conference. I'm going to turn this back over to Dr. McEwen. There are knowledgeable presenters coming up to help push us to look critically at how our own behaviors and system choices contribute to racial and other social inequalities as they apply to accessing treatment to substance use disorders, a subject matter that has become more and more important and obvious to everyone paying any attention at all. We then have knowledgeable facilitators to stimulate some challenging clinical situations, discussions, and we have 2 days to share and learn from each other so that we can do our best to do good, but as we do good, we can do our best to stay safe. Thank you all. Peace.